Hello everyone, welcome to My Way RT, the first class. We will be talking about the history of mechanical ventilation and the basic parameters in the mechanical ventilator and the initial settings. As you can see here, this is the very first mechanical ventilator was discovered in the 19th century by a Scottish physician called John in 1838. It's based on negative pressure ventilation. It's considered of a tight box, a patient sitting in a sitting position, and a manual pump that pumps the air in and out of the box. We will see here another old ventilator, also based on negative pressure ventilation. This is called the iron lung. This has been in the poliomyelitis epidemic patient. This picture was taken in California in 1953. As you can see here in the first picture, how it's working. It's like inserting the patient inside a room with a negative pressure, and the lung will be pulled and the patient will breathe through their mouth or nose with no intubation. Over time, the ventilator has been upgraded into the turtle shell here on the left and the rain cross on the right. The rain cross was wrapped with a wire grid and immersion 33 CRA negative pressure ventilation. This is the Bird Mark 7 and 8 and the Burton Bennett. Now let's talk about the types of mechanical ventilation. As you can see here, we don't intubate the patient immediately and use positive pressure. No, we try go gradually from O2 devices, low flow, then high flow, non-invasive, and finally intubate them and hook them to the MEC vent. Nowadays, we use the MEC vent as a positive pressure ventilation. What do we mean by positive pressure ventilation? That means we are forcing the air into the lung and the expiration will be passively. Unlike the negative pressure is like what we are doing right now, we're breathing normally. Okay, we will have here the volume cycle, the pressure cycle, and the time cycle. The volume cycle, it means that I set my volume and the pressure will be applied until the tidal volume is delivered, as I said. The minute ventilation here will be constant. What about the pressure? The pressure is the opposite. I will set my pressure limit and the tidal volume will be adjusted and it will be inspired depending on the mechanics of the line, patient's line. And we will have here a constant peak pressure. This gives me an advantage that it will protect the patient from having barotrauma. I will use this mechanical ventilation with a very sick patient like ARDS and the neonate. Time cycle. As it says time, that means I will set a time like let's say 1 second and the pressure and the tidal volume will be delivered in this 1 second. It will cut off. Now we will have some examples of volume modes like ACV. What do we mean by ACV? ACV means Assist Control Ventilation. It's another term for CMV. CMV is Continuous Mandatory Ventilation. It will have control and assisted breath. What do we mean by control and assisted breath? We will talk about it in the next slide. And SIMV. SIMV means Synchronized Intermittent Mandatory Ventilation. It will have control and spontaneous with pressure support, unlike the assistant. We will talk about the difference between these two. Pressure modes ventilation. We will have a pressure control ventilation. It has only control, but nowadays we don't use this at all. We add assistant to it so the patient doesn't fight with the ventilator and cause air trap. APRV. This is my favorite mode, but unfortunately most of the RTs and doctors are afraid of this one. This is a very unique mode. It's a shortcut for air airway pressure, release, ventilation. It will be depending on spontaneously breathing. It will deliver the breath in a high and low pressure with a set of high and low time. I rather to use this one for lung recruitment, especially. So if you don't know how to handle the APRV, please don't use it because you might injure the patient if you don't use it carefully and with experience. Dual mode. What do we mean by dual mode? That means it's a combination between volume and pressure. I rather this in an initial setting. It's a pressure regulated volume control, and the volume will be guaranteed under a set of pressure. It will always have control and assisted breath. What do we mean by control and assisted and spontaneously breathing? Control, that means when the ventilator is set at a number, it will give only the number. It will not allow the patient to breathe over it. Assisted, that means the ventilator will allow the patient to breathe in between the control, and it will help him when the ventilator sense the patient is trying to trigger. Spontaneously with a pressure support. Spontaneously with a pressure support, that means when I'm trying to breathe, I will set a pressure support that will help the patient to take a better volume, and I will decrease it over time until I let him breathe spontaneously on his own to test him if he can breathe on his own so we can take or decannulate the tube. Apnea, when we have a lack of chest movement for more than 10 seconds. Now, this is my favorite scheme. I took this from the Cervo Eye. As you can see here, we will talk about the basic parameters. Here will be the variable numbers like the inspiratory, expiratory tidal volume, the compliance and the resistance, and the plateau, and the minute ventilation and peak. Okay, and here we can change the mode if you want to set your alarms, and the waveforms that will help you to detect the air trapping or leakage. And here will be the set parameters. We will have the FiO2 and the PEEP. What do we mean by PEEP? The end expiratory pressure that will keep the alveoli open. We usually start for the adult by 5 and increase it depending on the patient chest X-ray and oxygenation. When we want to control the ventilation, we will have the RR, set RR, tidal volume or pressure control. If you choose a pressure mode, you will set the pressure control. If you choose a volume mode, you will set the tidal volume. Flow IE ratio are related to the RR. So whenever you change your RR, you have to readjust your IE ratio and the flow. So we will have here a very simple case that I see every day in the ER and the ICU to help us set the initial setting. You don't memorize settings and add it. Now, every patient is a different case, so I'll teach you a very simple way to adjust it smartly. So let's read the case. A 29 years old male, case of DLOC. What do we mean by DLOC? Decreased level of consciousness. Whenever we have a patient GCS below 8, we intubate them immediately. Here we have a sign of infection, thick yellowish secretion with fever, 39 Celsius degrees. And the heart rate is tachypneic, 130. The blood pressure is hypotensive. But in my ICU, the protocol, the policy is acceptable if the MAP more than 60. The RR is tachypneic, 32. And he's already been intubated with the tube size 7.5, lib level at 23. How do we check the lib level? From the chest X-ray. As you can see here, this is the tip of the tube, and this is the carina. So we have a very long distance here. That means the tube is short. We have to push at least 2 centimeters. We should have a gap between the carina and the tube level, more than 2 centimeter, 1 inch. Okay, as you can see here from the chest X-ray, the patient is having a congested from the secretion and the fluids here. That's why we have fever and yellow secretion. We'll try to do him some recruitment and CPT. The APG was taken at the beginning of the intubation. The pH is 7.28. That means he's acidotic, and the reason of because of CO2. That means it's respiratory acidosis with hyperoxygenation. So we don't have problem in oxygenation, only in ventilation. That's mean here. How do we choose the mode? As I told you, BRVC is a safe mode because I can control the pressure with guaranteed volume. So, as initial setting, I encourage to use BRVC. FI2, this was taken on 100% because he was embobagged by the 82. That means it was on 100, so why not making it on 60 or 65 and then go down gradually depending on the saturation and the next ABG. PEEP, I'll give him a higher PEEP than 5 because he needs lung recruitment, let's say 8 to 10. And watch the BP while increasing the PEEP because whenever you have PEEP, you will squeeze the heart and the BP will go down. The tidal volume is set by a special equation that I think all of the RTUs know that, but I have a simpler way to use in emergencies. When you take the last 2 digits of the height, like if the height is 160, take 60 and multiply it by 7 or your hospital protocol or policy kg. Okay, but for me, I think they will consider this one maybe as an ARDS because of the X-ray. So I'll multiply it by 6 and I will have my tidal volume here. I will set my pressure limit around 30 to 35. The RR, depending on the CO2, I'll make it around 20 and I will reassess it with another ABG after 30 minutes. And the IE ratio, I'll make it 1 to 3 seconds. I hope this is a brief and a simple way to teach you how to do your initial setting. And if you have any question, please don't hesitate. And thank you.